Good afternoon, and thank you, Madam Chairman. I'm Kaushik. I am a general rheumatologist, and I entered the world of osteoporosis about 10 years ago when a colleague of mine who was running the osteoporosis clinic retired. And for the last 10 years, for me has been a journey of discovery and learning. And I'm going to share with you some of the lessons I've learned. And the more I delve into it, the more I realize how complex it can be. And that's where my starting point is. I have no conflicts of interest. So broadly speaking, osteoporosis awareness has improved within the rheumatology community, although it cannot be said it's the same at least in the UK, in primary care or amongst our orthopedic colleagues. That is one of the interfaces we have is low trauma fractures. Part of the problem is there are many parents who'd like to have osteoporosis, but like endocrinology, rheumatology, gerontology, but no one takes ownership. And that means that patients fall between the cracks of who will be looking after them. Decision making for complex cases is often very subjective. And we have a network where we meet virtually in the Midlands, based around Birmingham and the West Midlands, where every 2 months we bring our complex cases, and there's about 15 to 20 of us with an interest in osteoporosis. And one can see from the discussions that there's such variability in terms of what people would do with an individual patient. And I think that has made an incredible difference to how we treat some of the more complex patients. We are still very much bound by the bone density scan, and although we've had a state-of-the-art lecture about what the future is, but for now we still have the DEXA scan as a standard tool, and that in a way colors our judgment as to how we treat these patients. And that also has now evolved into slightly more nuanced and more sophisticated fracture prediction tools, which I shall talk about. There are, at the end of the day, relatively few treatment options. You have antiresorptives and anabolics, and of the antiresorptives, you have either oral or parenteral. And the anabolics, so far, we only had teriparatide, and of late, certainly in the UK, we now have access to romosozumab. What I'd like to impress upon you as a rheumatology audience, you don't need me to tell you, that osteoporosis is a global health crisis, and we are sleepwalking into disaster if we do not take action now. As you can see that, by 2050, there will be almost 21 million hip fractures per year, and some of it will be in Romania. So I would like to say that, we need to at least target 80% of low trauma or osteoporotic fractures to identify and at least treat half of them to make some kind of impact on these numbers. Now, there has been an incredibly useful report by the International Osteoporosis Foundation, which I would recommend. It's slightly dated, but still quite relevant, and it's called Broken Bones and Broken Lives, which really illustrates the impact that fragility fractures has on the patient. There has been a report about Romania and into the epidemiology, burden, and treatment of osteoporosis, and I'm sure many of you will be aware of it. And we can see that there is still much work to be done in terms of tackling this problem. I will highlight the comment in the red circle that the number of fragility fractures in Romania is expected to increase by almost 15% between 2019 and 2034, with the potential impact on the healthcare budget. And I'm sure many of you will be involved in making interventions for these increase in percentage. So that is the scorecard. And there are some very good things as far as osteoporosis services are concerned, and there are others which my school report card would say can do better. So I think we have to be cognizant that there is a problem that needs to be addressed in terms of osteoporosis and osteoporotic fractures. In the UK, things are not that better. One of the problems, as I have alluded to, is there are many stakeholders, but no one really is pushing the agenda forward. There's wide variability between regions. Fracture liaison services and access to DEXA scanners is not uniformly good. I work in a university hospital which has 35 orthopedic surgeons, 8 consultant rheumatologists, about 10 endocrinologists, and similar number of gerontologists, and yet we have not been able to develop a fracture liaison service or an integrated osteoporosis service for the community we serve, which really is not ideal. There needs to be a much better infrastructure for education, particularly of primary care physicians, because most of osteoporosis management is in primary care. Secondary care and primary care need to work together, and there are incredibly good models of care, certainly in some parts of the UK, in Sheffield, in Oxford, in Bristol, which can be emulated. But somehow there are gaps in the services and a reluctance in the health commissioners to fund these projects. Knowledge to really expert advice is important, and now with the post-pandemic we have these virtual meetings which are very helpful for the individual patient with complex needs. We can and we should do better. So we need you to think about osteoporosis the same way as you do when you look at a rheumatoid or a lupus patient and you think of cardiovascular risk and the annual review that has been mooted by the organizations like EULAR and ACR. Osteoporosis is very much an important part of our patients' overall health. Why do fragility fractures matter in a healthcare setting? This is data from the Oxford region, a slide lent to me by Professor Qasim Javed. And as you can see, if there are around 15,000 fragility fractures and nothing happens, then in 2 years' time, about 1,700 of them will refracture, of which 700 will be hip fractures. They will take up beds, they will account for emergency hip surgery and extra patients in long-term care, all of which comes at significant cost, and a lot of that can be avoided if we have good fracture liaison services. So we've heard about how it affects the community. Fragility fractures has an incredibly important impact on the individual, and therefore it is our responsibility to have a working knowledge of how to deal with and identify patients who are at risk of fractures or who have had an index fragility fracture. So if you think about a hip fracture and the consequences of a hip fracture over a year, 1 in 5 will actually die after 12 months, not necessarily because of the fracture, but the consequences of a hip fracture, which includes admission to a hospital, having anesthesia, having surgery, and so on. And you can see up to 80% will be unable to carry out at least one independent activity of daily living. So it does matter that we intervene adequately after these patients come to our attention. As we have heard, that bone quality depends on a number of different things. For the time being, we are very much concerned about bone density, which is an important marker of bone health, but we have to remember it is not the only factor. There are other things that, the previous talk very exquisitely alluded to, the architecture, damage, and there are new techniques by which we can measure that. But bone strength is, for now, the surrogate marker is bone density scan. And for a very long time, we were locked into treating the bone density scan result rather than the patient's fracture risk. Now, broadly speaking, the aims of managing osteoporosis is to reduce incidence of fractures. You could either have primary prevention policies, which is mainly in primary care. For us in the rheumatology clinic, it's more secondary prevention after someone has had an index fragility fracture. It is important for us to identify these people and to be able to assess their fracture risk accurately. So in terms of bone density and the WHO definition, we are all familiar with this, but we have to remember that this is not the be-all and end-all of how we frame our clinical decision-making. Over the last 15 years or so, we have evolved significantly, and we now have better ways of using the bone density to try and calculate a patient's individual fracture risk. There are many such fracture risk prediction tools, of which FRAX, which was developed in Sheffield, is probably the most commonly used. Why is DEXA an important and useful tool? It is relatively less costly, it is affordable, it does vary in terms of accessibility from region to region or country to country, but if you have access to it, it gives us a good working knowledge of what the bone quality is. However, there are many disadvantages, and I've highlighted just the one which we have to remember. In countries, certainly in the developing world, where there is chronic hypovitaminosis D, the bone density scan does not distinguish between osteoporosis, which is less bone, and less mineralized bone or osteomalacia, and it is important to remember that. So going on to the fracture prediction tool that is widely used, it is probably the most commonly used globally, is FRAX, and there is one, and it has a number of risk factors, as you are well aware, and it is then used with or without the bone density scan, and that is one of its advantages. We can actually calculate a 10-year fracture risk score without having a bone density scan, and that is why its usefulness in primary care or in areas where bone density scans are not easily accessible. There is one that is purely designed for Romania, and there is also the uses of FRAX. It is mainly designed for use in primary care, but it is also used extensively in secondary care. And it is used to integrate a number of different epidemiological risk factors into a finite score that then allows us to use those scores of 10-year fracture risk and hip fracture risk to decide whether we should intervene or not with active treatment. Or in other words, whether these risks, this probability crosses the intervention thresholds. And I'll come to that in a minute. So here we have someone with a major osteoporotic fracture risk of 29% and a hip fracture risk of 16%. As a rule of thumb in the UK and to some extent in the US, if the 10-year fracture risk crosses 20%, we would say it is worth intervening, and for hip fracture, it is around 5%. This varies from country to country, and for Romania, it's been, as you can see, this is what is relevant to UK, and we have a tool within the FRAX embedded, which takes us to what is called the National Osteoporosis Guidance Group, and the individual patient's risk, as you can see in that black cross. This is a patient where we have to intervene. Similar thresholds have been worked out for Romania as well, and this is a paper where you can find what the intervention thresholds are for Romania. The limitations of FRAX are many, and it has been recognized. It does not account for the frequency of falls. It does not account for some of the other comorbidities like diabetes. It does not account for the steroid dose. For example, we know osteoporosis is a steroid-induced osteoporosis is dose-dependent, and so on and so forth. And finally, the FRAX does not replace clinical judgment. Ultimately, the clinician will have to make a considered judgment on whether to intervene or not, because these drugs, although effective, also have problems in the long term. Because of the limitations of the current FRAX, there is something called the FRAX Plus, which is in development. This is a slide courtesy of Professor Eugene McCloskey, who's one of the key founders of the FRAX tool, together with Professor John Keynes, and this is going to be launched very soon. And some of the advantages of FRAX Plus is it takes into account some of the risk factors that have not hitherto been part of the original FRAX, but also it adjusts to the probability of recent fractures. So there is a correction that is given to the ultimate score if someone has had a recent fracture. And as you can see at the bottom panel, the time since the previous fracture and the site, they all go into this algorithm to give a more refined fracture risk tool. There is also this guidelines, which I would recommend, although it is UK based, but I think you'll find it incredibly useful, and it has, it's a very long report, but well worth, those of you who have an interest in osteoporosis, well worth looking into it, and it is quite a comprehensive document. Some of the key elements of the new guidelines, this is an update from 2016, I think it was the last one, is this concept of very high fracture risk and the consideration of specialist referral. That's come up with new post-frac NOG thresholds, which takes into account the recent fractures, if someone's had a recent fracture, and also it determines intervention thresholds for patients who are too frail to go to have a DEXA scan. I often have patients who will flatly say, I really cannot come to hospital for a DEXA scan, and then you'll have to make an informed judgment based on other clinical factors. As far as treatment is concerned, the general trend now is to give at least 5 years of oral bisphosphonate treatment as standard. The word holiday, the drug holiday that was so prevalent in the past, has now been replaced by drug pause. Somehow it is felt that drug holiday does not do the concept of a drug pause justice. It's a matter of semantics. I'm not particularly sure I care either way. There has to be routine reviews of tolerance and adherence. It is well known that oral bisphosphonates are poorly tolerated, and by about a year, almost 50% of these patients who are prescribed oral alendronic acid or risedronic acid will not be taking it. And we have to make sure that they are either taking it, and if they are not for very valid reasons, we should then change to parenteral treatment like IV zoledronic acid, for example. IV zoledronic acid is still considered to be the first-line treatment, and denosumab is reserved for patients with special needs, or if there's any reason why we can't give them a bisphosphonate. Anabolic treatment has now become much cheaper. We now have biosimilar teriparatide, and that has changed our thinking around anabolic treatment, and we will have a talk, the next talk will tell you a bit more about how anabolic treatment can be positioned as the initial treatment, particularly in patients with very high risk of fracture. One of the things about denosumab, and I'm a great fan of denosumab, having been involved in one or two of the trials initially, is denosumab cessation. Please remember that if denosumab is stopped, the benefits of denosumab regress within 6 months, and there's this rebound phenomena that the bone density gain will regress below the baseline where one started. So it is very important, if in patients who are on denosumab, if they for some reason cannot continue on denosumab, to try and give IV Zol or a similar drug, a bisphosphonate, to try and maintain the osteoporosis gains from the denosumab treatment. We have heard a little bit about vertebral fracture and its detection. And so the current NOG guidance, and it has to be said this is mainly for UK patients, but it's, the principles remain the same. You have low risk, high risk, and very high risk. And in patients where bone density scan results are not available, it tells us when to try and do a bone density scan to fine-tune our therapeutic decision. So in very high risk fracture risk patients, we now have adopted the initiation with anabolic treatment. And it is well known that if a patient with very high risk of fragility fracture does get anabolic treatment, either teriparatide for 18 months to 2 years or romosozumab for 12 months, you have the best chance of consolidating the gain followed by a potent antiresorptive. A little bit about drug pauses, or what used to be called drug holidays. Normally, we have, oh, I'm going the wrong way. Normally, as I have said, we would carry on with a bisphosphonate oral bisphosphonate for 5 years and parenteral IV zoledronic acid for 3 years before considering a drug pause. The reason we think about giving drug pauses is to try and minimize some of the rare but significant side effects that one can see with long-term use of antiresorptives. One of which, of course, is bisphosphonate-related osteonecrosis of the jaw, and this is one of my patients who had, as you can see, a through-and-through fracture of the mandible, and this was after 7 years of oral alendronic acid treatment. And the other is atypical femoral fractures. Time does not permit for me to digress and explain a little bit more about how these present, but if you have a patient who attends your clinic for whatever reason, and they are on a bisphosphonate, please do ask them at least once a year about whether they have any thigh pain. That is something that is very, very important, and it's usually in the mid-thigh region that they might complain of pain. Some of the other considerations that we need to think about while deciding whether to treat a patient or not. We've talked about secondary prevention. Steroids, of course, are very important in being one of the important causes of osteoporosis for our patient population. The bone density scan, the technical aspects, again, are very important, and we try and get the patient to have the bone density scan done in the same scanner. There is this concept of least common difference, and if they have the bone densities done sequentially in different scanners, it is very difficult to interpret the differences between one scan and the next. The FRAX, of course, we've talked about its limitation. In the UK, we would recommend treatment empirically if there is a fragility fracture on steroids, or if there's a fragility fracture in someone who's over 70 years old. Certainly in our patients with rheumatoid and other forms of inflammatory arthritis and connective tissue disease, the threshold of starting treatment is relatively low. Increase of major osteoporotic fracture risk by 10%. This is another important concept. FRAX is calculated on the hip bone density. And quite often there is a difference between the T-score in the hip and the lumbar spine. So for example, if you have a hip T-score of minus 1.5 and you've calculated FRAX, but the lumbar spine, say L4 is minus 3.5, there is a difference of minus 2. And there you have to put in a correction. For every difference of 1 standard deviation difference, or in other words, in this case, 2 standard deviation difference, you add in 20% to the major fracture risk score. So sometimes if you calculate a FRAX that is below the intervention threshold, but the bone density in the lumbar spine is less, you have to make some adjustments to truly reflect the patient's fracture risk, because the patient will fracture where the osteoporosis is at its most. If the hip is not truly reflective of the patient's whole bone profile, but the spine is worse than the hip, you have to make some adjustments. And again, for diabetes, still FRAX Plus comes in. Select rheumatoid arthritis as a risk factor to give you a practical way around calculating FRAX. A little bit about switching. So how do we monitor drug effectiveness? There are many ways of doing it. One of, in some centers they use bone turnover markers, but generally speaking, we look at clinical outcomes. If they have fractures whilst on treatment, if the bone density is declining despite treatment, and obviously if you have access to bone turnover markers, they are very useful. Treatment failure is the so-called rule of twos. 2 or more fractures whilst on treatment, decline in the bone density and 1 fracture, bone turnover markers that are not suppressed, and a fracture, and so on. If there is a lack of efficacy, then one should consider whether the compliance is adequate or not. Or they have developed some other comorbidity, or they're on higher doses of steroids than you think they are, and so on and so forth. If there is fracture on treatment, we should be careful in considering the fracture history. Not all fractures are fragility fractures. We must ensure that adherence is there. If the patients are not taking the drug, we don't expect them to get benefit. The false risk is something that we don't particularly look into very carefully, certainly not so much in the rheumatology clinic, and yet, the incidence of fractures will go up several-fold with the same bone density if a patient is prone to falls. And of course, we have to think of other secondary causes. So as I come to the conclusion of this talk, I'd like to highlight some of the unmet needs in osteoporosis and why we as a group of rheumatologists, wherever we are, we can do better. Obviously, the public health issue is about optimizing peak bone mass in young adults, but we must ensure there is better awareness of the condition among stakeholders, including our politicians and the people who are commissioning healthcare. There is a huge amount of treatment gap between patients who are having low trauma fractures, and also we don't do enough to ensure better compliance. The vitamin D and calcium story is a completely different talk, but we must make sure that our patients are vitamin D replete if we are going to give them bisphosphonates, and we must try and develop better falls prevention programs and fracture liaison services. We've already had a talk around better diagnostic tools that are in the pipeline. And the reason for doing that is this is how patients with low trauma fractures feel. This was a survey conducted by what was then the National Osteoporosis Society, is now called the Royal Osteoporosis Society, and this is what patients told us. This is how they feel after they've had one or more low trauma fractures. And it makes uncomfortable reading as a healthcare provider to hear this from our patients. And therefore, we must do better. We must not forget the human cost of an avoidable osteoporotic fracture, ladies and gentlemen. And therefore, I'd like to end my talk by saying fragility fracture begets more fractures. This is called the cascade of fractures. And what we must try and do is to stop at one. Thank you very much for your attention.